For coming to our presentation today on understanding neuropathic pain. So I would like to begin by acknowledging that we live and work on the traditional territories of many Indigenous nations across Turtle Island. While we meet today on a virtual platform, we must recognize the importance of the land and our treaty agreements. We acknowledge the ancestral and unceded territories of all Inuit, Métis, and First Nations peoples. As our Spinal Cord Injury Ontario community encompasses many geographies, we ask that everyone take a few moments of their day to find out which unceded or treated territories you may live and work on. You can use the link www.native-land.ca to learn more, and that will be put into the chat box. So my name is Julie. I am a peer support coordinator for Spinal Cord Injury Ontario in the London region. My coworker today is Jaspreet. She is also a peer support coordinator, but in the Toronto region. So I just want to let you all know we will be recording the session today. So if you do not wish to be seen, please ensure that your video is turned off or your camera is turned off. We will also be keeping everyone on mute as to cut down on the background noise. You are more than welcome to ask questions throughout. So you can either raise your hand using the raise hand icon, or you can type your questions in the chat box and we'll be managing that throughout the presentation. So we've got a great session today. We're joined by Dr. Kendra Todd. She earned her PhD from the University of British Columbia, where she specializes in neuropathic pain and spinal cord research. So I will let Dr. Todd take it from here to tell us a little bit more about herself and her research.
Awesome. Thank you so much, Julie. I'm just going to share my screen here, and it might just take me a moment to get to it. Okay, and is that being communicated appropriately now? Everyone can see my slides?
Yeah, we can see it.
Perfect. Okay, so again, thanks, Julie, for the introduction. I'm very happy to be here today, as although I live in British Columbia currently, I have many SCI peers who live in Ontario, and I'm always happy to see the work and the networking that is being done across SCI Ontario. I'm here today to discuss a general overview of neuropathic pain, but I'm going to be focusing in a little bit on the role that exercise plays in neuropathic pain management, and also how important it is for people with spinal cord injuries and their support providers to be informed of better ways to communicate their neuropathic pain in order to maximize this opportunity for reducing overall pain intensity. So let's see if this works here. Okay, so I grew up on the traditional lands of the Haudenosaunee and Chippewas, now known as Innisfil, Ontario. I moved to the ancestral, traditional, and unceded territory of the Syilx Okanagan Nation in 2016, of which I've been able to experience sunrises and sunsets over Lake Okanagan and complete my graduate studies at the University of British Columbia. When I take walks on the various trail networks in the city of Kelowna and look at the vast contrast between the mountains and our lakes, I'm constantly reminded how grateful I am to have the opportunity to live, work, and play on this land of which I am an uninvited guest. Before I begin, I would like to acknowledge that I personally do not have a spinal cord injury. Therefore, my talk will be based on a combination of research knowledge and information provided through lived experience of many research partners with spinal cord injury. However, my involvement in the SCI world has not solely been focused on research. Throughout my graduate studies, I became involved in supporting our local wheelchair rugby team, and my involvement has grown, whereby I now coach our local Okanagan Rattlers, and I'm part of the coaching staff for Team BC's wheelchair rugby team. I supported the development of Canada's first women's wheelchair rugby team and coached this team to a third place finish at the Women's World Cup in Paris, France in 2023. And I've also supported the development of the first adaptive downhill mountain bike circuit in British Columbia and worldwide. Throughout my involvement in many areas of parasport, I also have met my partner, who also has a spinal cord injury and experiences neuropathic pain. Therefore, while I do not have lived experience of a spinal cord injury nor neuropathic pain, through conversations with my partner and many close friends with spinal cord injuries, my passion only continues to grow to be able to learn more and support those who do experience a spinal cord injury and neuropathic pain. To give you a little bit of a brief outline of today's presentation, I'm going to begin by providing a general overview of neuropathic pain, followed by discussing treatments that are commonly prescribed by healthcare practitioners. I'll then go into a little bit of detail on how exercise can influence neuropathic pain symptoms. And then I'm going to finish with a set of tips that may support you in identifying optimal neuropathic pain management. And if you hear my dog barking in the background, I do apologize. She might be a little bit excited seeing some things out the window, so I'll try to keep that to a minimum. So when talking about neuropathic pain among people with spinal cord injury, we must first be able to distinguish it from musculoskeletal, or what is also considered nociceptive pain, depending on who you're talking to. So musculoskeletal pain can be defined as a pain occurring in parts of the body where an individual still has preserved sensation. That is due to actual or like slightly occurring tissue damage within muscle or skeletal structures. Think of things like your muscles or your tendons or your ligaments, joints, those types of things. In people with a spinal cord injury, musculoskeletal pain often occurs due to overuse injuries, frequent wheelchair propulsion, or sports injuries. While less common and often forgotten about, musculoskeletal pain can also occur below your neurological level of injury. So for example, if you are a C6, C7 tetraplegic, you can still experience musculoskeletal pain in your buttocks or in your lower legs. Examples of when to consider your pain as musculoskeletal include when your pain intensity may be affected by moving or changing your position. When you touch your injured area, these structures affected are tender to the touch, and they kind of give you that painful response. Where you sense your pain, it can also be backed up by imaging, such as X-rays or MRIs. Or when you experience this pain, if you use an anti-inflammatory or an opioid medication, it directly influences that painful response. So basically, when you take this anti-inflammatory or opioid and your pain reduces directly, it's often considered to be a musculoskeletal or a nociceptive type pain. But getting into neuropathic pain affects approximately 50% of people with a spinal cord injury and is often reported to be more debilitating than the injury itself. So neuropathic pain can be defined as a disease or a lesion of the somatosensory nervous system. It can be categorized into two main types: at level or below level neuropathic pain. So at level pain is pain at your neurological level of injury, or anywhere up to sort of 3 small regions below. This pain can often feel like a corset or a belt or something squeezing right around this level of injury. At-level pain usually starts early after SCI, often when you're in the hospital or in your acute rehabilitation stages. Whereas below-level neuropathic pain is anywhere below this neurological level of injury and usually develops over the first year of injury, with statistics saying it's usually within about 6 months to a year and anywhere up to 2 years following your spinal cord injury, where this below-level neuropathic pain usually starts to happen. Now, of course, the somatosensory nervous system is not exactly something that's in our daily vocabulary. So let's break this down just a little bit further. So the somatosensory nervous system includes hundreds of pain receptors located throughout your body. So these pain receptors are all specialized and they help the body to feel different things, such as a pinprick or burning hot water or soup in somebody's lap, in order to help the brain react and respond to this sensation. This sensory information is then sent back to the central nervous system, so your brain or your spinal cord, to process. For people without paralysis, your brain reacts and responds appropriately to this painful sensation. For example, if you were to touch a hot stove, the brain will receive this information about the painful heat and then tell your body to remove the hand from the stovetop. For people with a spinal cord injury, there's a disconnect between the information that the pain receptors are sending to the brain and then the information that the brain is sending back to the rest of the body. You can kind of think of this mechanism as a brake, and when this brake isn't working, then pain signals reach your brain and then your body at a greater strength than they would if you did not have a spinal cord injury. So this is kind of a short form explanation of what causes neuropathic pain and also shows why it is tough to understand and then to subsequently treat. So neuropathic pain commonly manifests into two characteristics: allodynia and or hyperalgesia. So in this figure that I have on the screen here, you can see that this vertical line shows something that's about your pain intensity. And on this line that goes sideways, we see something called a stimulus intensity. Now, if you can see a green line that indicates an average unparalyzed individual's sensation to pain. So allodynia, which is that little red curve, is a painful response to something that should not be painful, such as being brushed in the leg with a feather. Whereas when you see this blue response, which there's a big gap between the green pain response, which is the average individual, and this blue response, that's known as hyperalgesia, which is this really, really severe and heightened painful response to something that would actually be painful, such as being hit in the leg with a hammer. Other neuropathic pain symptoms that have been reported are burning, tingling, squeezing, or shocking, just to name a few. But as I'm sure you're all aware, neuropathic pain is not strictly physiological. Rather, it's a complex sort of biopsychosocial phenomenon that we can't really fully understand without understanding how neuropathic pain intersects with our entire life. So things like the quality of social relationships, or satisfaction with life, or satisfaction with things such as your family environment or employment or housing stability, these can all actually influence your overall pain experience. So research has also shown that something that's called pain catastrophizing, which is basically hyper focusing on how much pain your body is feeling, as well as being in a negative mood or having a negative mood, have a really strong relationship with how intense your neuropathic pain is. So the more you think about your pain and you magnify the amount of pain that you're in, oftentimes the more intense your pain actually feels. In contrast, people who report greater use of pain coping strategies, so things such as distracting yourself, often experience lower neuropathic pain. So therefore, it's unsurprising that individuals actually often report that their neuropathic pain is worse in the evening when their minds are less busy and it's easier to just focus directly on how severe your neuropathic pain is. So it's very important to figure out strategies that distract you, such as playing a game or doing an activity, watching television, or removing yourself from whatever present situation you currently find yourself in order to get through these sort of high intensity pain moments. Beyond the physical and psychosocial symptoms of neuropathic pain for people with a spinal cord injury, neuropathic pain triggers often vary across individuals. For some, sitting in the same position without doing pressure shifts may worsen your neuropathic pain, whereas for others, it may be things like an undiagnosed urinary tract infection or being extremely tired or really intense muscle spasms that actually trigger bouts of neuropathic pain. So it's really important to think about beginning to understand and monitor what lifestyle conditions may worsen your own individual neuropathic pain in order to support you in starting to take control of your pain. And before I go further, do we have any questions? And I can't see all the hands if there are any, so I just might need to be guided if there are.
Yep, nothing in the chat box so far.
Perfect. Then I can.
And I don't see any hands. If anyone does have any questions, if they just want to unmute themselves and you can ask.
Okay, we're good to go.
Good.
Awesome. Okay, so as I'm sure you're all aware, for most individuals who experience neuropathic pain, when they're talking to their healthcare practitioner, the most often prescribed treatments for neuropathic pain are pharmaceuticals. In 2016, an international group, so all over the world, of neuropathic pain and SCI researchers got together in order to evaluate the state of the research evidence with the aim of identifying the most effective neuropathic pain treatments available. So they wanted to see what the research is saying in order to actually be able to translate that into clinical practice. So amongst pain research, studies usually investigate how effective a treatment is in decreasing pain compared to a placebo or a non-effective treatment. So if the treatment is more effective than the placebo, it provides evidence that it works. When a specific treatment is not evidence-based, it means that no study has shown that the treatment works, Basically, in this case, that it actually reduces neuropathic pain better than a placebo would. However, even when a treatment is considered evidence-based and has worked for others, there is no guarantee that it will work for everybody. Based on the limited available evidence, because research amongst neuropathic pain in people with spinal cord injury is still in its infancy, the A-level treatments for neuropathic pain, so these first often prescribed treatments, are pregabalin, gabapentin, and amitriptyline. So things like Lyrica, which is often the brand name associated with a lot of these treatments, have the most evidence for treating neuropathic pain after spinal cord injury. However, because the pain experience differs for each person, not every medication works for every patient. And even if it's considered the best treatment and it doesn't work for you, something else likely will. When we're thinking about starting a new medication as well, it's really important to start slowly in order to ensure that your body can tolerate the medication. And because neuropathic pain is often difficult to treat, we can also remember that it's important to use different or multiple methods in order to deal with it, because one treatment might give you a 10% improvement here, 10% here, 10% here, which then really increases that overall percentage of your pain reduction. So these conversations of figuring out sort of what works for you are really important with your close family, friends, and your healthcare team. So you can really start figuring out what treatments and combinations of treatments are successful, or if you want to stop taking a drug because it simply doesn't work or the side effects are too strong.
Dr. Todd, sorry, we just have a comment in the chat box.
Awesome.
Somebody said tried all three, none worked, and then somebody just said same.
And that's something that actually is consistently reported by people worldwide who participated in research studies. What we found by a lot of the pharmaceuticals is that they only lead to about a 30% pain reduction for only 50% of people who experience neuropathic pain. So clearly there's a really, really important need, for developing new and improved strategies, as well as really, really listening to individuals with a spinal cord injury, because oftentimes they're the ones who are able to really identify what works more than just what listening to a research study can, because pain is so individualized. And so we're going to get into a little bit more of these kind of self-management strategies as well, because although in research, which has just been highlighted, that these pharmaceuticals are the most effective, they don't always work for everybody. So a variety of other treatments were included in these CAN-PAIN spinal cord injury pain management guidelines. These options include things like tramadol or electrical neurostimulation or cannabinoids, so cannabis, which reinforce this understanding that neuropathic pain is so individual and treatment cannot be a one-size-fits-all approach. It often takes a plethora of treatment options before finding something that truly works for you, especially because these pharmaceuticals, as we said, don't quite work for everybody. So one self-management option that has been reported to be preferred by individuals with SCI and neuropathic pain is exercise. Limited research was available at the time of the publication of these pain management guidelines on how exercise actually does impact neuropathic pain, which further limited its ability from being included as that kind of A or top level management option. Therefore, in my research program, we aim to better understand how exercise could contribute to neuropathic pain reduction and then better inform future iterations of these pain management guidelines that are actually guided by people with lived experience. So to begin understanding how exercise influenced neuropathic pain, we knew we had to do a deep scan of all the published research. Based on the known inconsistencies, and I'm sure many people on this call would agree, that neuropathic pain is often misdiagnosed and miscategorized, and that exists also in the research world. So we took a little bit of a step back and we aimed to synthesize available research that looked at the relationships between physical activity, all types of chronic pain, and overall well-being in people with a spinal cord injury. So even though we took this big step back, only 15 published research articles actually looked at this interrelationship, which in the grand scheme of things for people who experience pain is a pretty low number. However, we were pleased to see that 12 of these 15 articles suggested that physical activity reduced chronic pain and improved overall well-being for people with a spinal cord injury. So based on these positive impacts, both on pain and well-being, which we know directly contributes to that overall pain experience, it did become clear that we had the rationale to kind of continue investigating this impact of exercise on chronic pain. While it's fantastic that research evidence demonstrated that exercise could positively influence chronic pain, and it provided us with rationale to continue investigating this relationship, really and truly, this doesn't matter unless we also had SCI community buy-in. So if people living with a spinal cord injury and neuropathic pain didn't believe that my research program was relevant or useful, it really doesn't matter. So my entire research program, together with my lab, which is SCI Action Canada, is grounded in community-based and community-driven knowledge. So individuals with SCI lived experience were involved in each of my research projects from start to finish, including the design of the research project through to publication of each research manuscript. Research has no impact if we're not speaking the right language or answering the right questions. And I truly could not have completed this work without my fantastic research partners, many of whom you can see on the screen here. So as I mentioned earlier, 15 different research articles were published investigating the relationship between exercise and pain. Of these articles, 3 specifically focused on neuropathic pain. But these exercise protocols were vastly different. Participants engaged in various types, lengths, and intensity of exercise protocols. However, all the results were positive, where exercise reduced neuropathic pain by at least 30% in each study, which in the research world is considered something to be clinically significant, where if your pain doesn't decrease by at least 30%, it doesn't necessarily have a real world impact for people living with pain. But these 3 large questions remain, of course, because of the varying exercise protocols. We still don't know what the optimal dose, frequency, or intensity of exercise required is to elicit this overall really impactful pain reduction. So to start tapping into understanding what the optimal amount of exercise is, we conducted 2 separate studies. And I'm just going to kind of summarize the results here because I'm well aware that none of the nitty-gritty aspects of each kind of research study is really impactful. And I would probably forget it myself if it wasn't me who actually did it. So first, we completed a study in our research lab that involved participants engaging in 20 minutes of moderate intensity aerobic exercise using an arm crank ergometer. We looked at this length and intensity of exercise because it was the most relevant to the general SCI population, because according to the SCI physical activity guidelines, it is recommended that the average intensity and length of exercise engaged in is 2 bouts of 20 minutes of moderate intensity aerobic exercise per week. So we evaluated participants' neuropathic pain using a variety of questionnaires before they started exercising, immediately after they finished, and after a 90-minute rest period. 4 tetraplegics and 4 paraplegics participated in the study, and the tetraplegic participants experienced this kind of reduction in their pain that's considered clinically significant from immediately before to immediately after exercise. But this change wasn't really sustained after they had a 90-minute rest. For our paraplegic participants, however, they also experienced a decrease in their neuropathic pain, which also sustained over that 90-minute rest period. So based on these differences that we observed between tetra and paraplegic participants, we identified that these exercise-related changes in pain are likely dependent on exercise intensity. Based on these results, we then completed a study which aimed to investigate neuropathic pain between Paralympic and recreational athletes with a spinal cord injury. This study took place during COVID-19, so some of our protocols had to change, but the benefit of that was that we were afforded the opportunity to include participants from across the world. So we had participants complete a variety of questionnaires regarding how much exercise they do per week at varying intensity levels, how they felt their neuropathic pain daily, and a variety of other psychosocial measures. We did have a very diverse representation of injury levels and severity, as well as individuals were engaging in a wide array of different types of sports. And we also had a representative split of males and females in our participant group. So results from this study show that Paralympic athletes, so if we're trying to generalize that, people who are engaging in a lot of exercise at a pretty high intensity, actually reported worse neuropathic pain than our recreational athletes, who more often engaged in moderate frequency, so think kind of 2 to 3 times per week, and moderate intensity exercise, So something that gets your heart rate up just a little bit, you're a little bit breathless, but you can likely continue this exercise for a long period of time without getting injured or experiencing a lot of fatigue. So these results show that it might just be more than exercise intensity that influences neuropathic pain, and the frequency may matter too, because we found that greater amounts, so a high amount of moderate intensity exercise per week was related to worse neuropathic pain. So given that our recreational athletes did not experience as bad of neuropathic pain as our Paralympic athletes, we identified that there might actually be a frequency threshold in order to reduce neuropathic pain among adults with a spinal cord injury. Now, I recognize there was just a lot of information shared on how exercise can influence neuropathic pain. So now you're probably wondering, Kendra, if I were to remember one key thing from how exercise might help my pain, what is it? So basically, what we found is that exercise might actually be a valuable management option for neuropathic pain. However, it's important to note that too much moderate intensity neuropathic pain may be related to worse neuropathic pain, whereas smaller, less frequent bouts of higher intensity exercise may be related to better pain outcomes. But again, because pain is such an entirely individualized experience, it's important to keep track yourself of how hard you're exercising and how often in order to identify what exercise doses maximally help your own individual neuropathic pain. And I will stop for questions just in case there are any here.
Oh, my dog, sorry about that, because there is a question, or actually, sorry, there's a comment in the chat box. Someone had just said, find the pool is best for range of motion and ease of use.
Absolutely. That's something that actually was reported because the pool can also sort of influence temperature receptors as well in your body, whether it be a little bit cooler or a little bit warmer. That can influence pain from a physical perspective. And just knowing that you're moving your body and doing something that supports, whether it be your mobility, doing something for exercise, doing something for pleasure, can all be connected to this pain experience. That's a really, really valuable tip that I've heard many of my friends who also use this option in order to reduce their pain.
No other questions or comments in the chat box, but again, if anyone wants to ask or make a comment or anything, please feel free just to unmute yourself. Oh, we do have a question. Okay, so just curious, could you go over how you, as the team coach, how then you help the athletes who may be experiencing more neuropathic pain and negative emotions coming from it?
That is a very loaded question. I would say first, it's really important to get an understanding of an individual's life as a whole. So I really try to take an interest in my athletes' lives, really understand what things could be contributing to their neuropathic pain. I try to understand when their pain is, when it's worse. Some people identify that it's really bad when they're driving to the gym for practice. And then we try to talk about, okay, maybe it's your seating arrangement in your car that is really putting a lot of pressure on your buttocks that is causing you neuropathic pain in your butt or in your groin or something, which is something that I've heard from some of my athletes. So let me try to modify that from like a symptom-based initial response kind of approach. But then when we kind of start thinking in how overall well-being plays into this pain experience, it's really, really important to say, okay, how can I help you cope with your pain? Here are some examples of distraction techniques, whether it be some people pray for the pain to stop. Some people just take control and say, you know what, pain, not now. I have something to focus on for 1 hour. I need to be on my game, on the court, and I will let myself think about this pain when I'm done my exercise. So we try to really start breaking it down for what happens with each individual and really to start identify kind of these distraction techniques. But it's a really interesting point that you bring up, because what we found is that there's a lack of disconnect, which I'm actually just about to get to, in how neuropathic pain is communicated, as well as how it's understood from parasport professionals, healthcare professionals, people living with SCI lived experience. So I think it's really important that we help facilitate this sort of knowledge-driven approach so that we're able to say, here's some good common words, here's some good symptoms. Let's make really informed decisions to make sure that everyone is being best supported in their pain journey. And hopefully that that helps a little bit, or that gives a little bit of an answer. And I'm happy for any follow-ups after as well.
We do have a hand up. So yeah, go ahead and ask your question.
Hey, Julie. Hi, everybody. I've been living with neuropathic pain for about 28 years now. It's got to the point I was hospitalized once for it, spent close to 3 weeks. All they did was lots of morphine, and they just doped me up, and then they said, "Oh, then you can go to an old age home to rest." And I told them where to go, but it just said that's not going to happen. The last 3 years, I got into a study out of Parkwood. I'm in Brantford, but Parkwood's London, and it's exercises, boxercise, and it went for I think 10 or 12 weeks. As a group, we decided we'd keep it going afterwards. We kept it going for about 5 months, and then Parkwood started online yoga, aerobics, boxercise, and that 5 days a week, strength training. So I've been doing the exercises pretty well 5 days a week for the last 2.5 years. And I found that there's a really drastic drop in my neuropathic pain. That's the way to explain what I go through is like if somebody took a syringe full of gasoline and stuck it under my skin and lit it on fire. And that's what I experienced. But the exercise has been helping dramatically in that. I've tried gabapentin, Lyrica, like gabapentin to almost like the upper limits of it with no success for years. And I just finally told him, please take me off this stuff. And just all it was good for is hot flashes, where you want to tear your clothes off and then roll in the snow. That's how bad it would get. And but the exercise, I would say that that's been a real great upgrade for me over the years. And
thank you
really
so much for sharing that experience. And I think it's really valuable that you contributed that you've tried so many different other types, and that there was a disconnect between your healthcare team and what you actually wanted, right?
Yep.
Like you voiced that you didn't want to go to an old age home, which is
That's right.
an experience that is often shared because, that's not the stage of life that you're in at the moment.
No.
And it's also that's not treating the root cause, that's not treating the pain, right?
No.
And morphine is treating this sort of overall intensity maybe, but it's not necessarily getting to the sort of pain break and helping your nervous system, which is kind of what I explained at the very beginning of this talk. And so I think it's something that's really valuable that you found something that worked for you. So at Parkwood, and I know the research group there very well, and many of them
They're awesome.
They're fantastic. And
Yeah.
many of them were involved in the development of these SCI pain
Oh,
management.
great. That's so good to know that. Yeah.
They're
been
fantastic.
So helpful. Yep.
So informed. And I think it's a really, really good tip that you didn't stop trying, right? You didn't stop trying to find this
right.
pain management option.
Yeah. You just have to keep on pushing until you get what works. It's just it's too miserable, the pain. Like I'm on Butrans. I don't know if you're familiar with that drug, and I'm on a really high dosage of that. I've had 5 spinal cord surgeries, 4 lower back after 4 lumbar sacral after my accident. And then I had my neck done 7 years ago, and I'm looking at having my neck fused from the back from, I think C1, they said, down to thoracic in the next number of months. So it's anything I can do to stay fit and, and keep that pushed down, I'm going to do. So this is when I seen this advertised, I said, I've got to be there. So,
well,
yeah.
I appreciate your attendance and that you're obviously I'm speaking from biases. The benefits of exercise on your overall well-being are so widely known. So I'm a huge proponent of exercise from a perspective of pain management and, the benefits it can have to your mental health. So knowing that you're going through so many different also procedures upcoming, it's a great idea to keep exercising.
And even the doctor, my surgeon, said the same thing. He said, my wife said, can he still exercise? He said, absolutely, please keep exercising. So I said, okay. So,
Awesome.
yeah.
It's a good tip to keep sharing with all SCI peers that the benefits
Yeah.
far outweigh the negatives.
Oh, they do. They do. It's absolutely wonderful, the exercise. Yeah.
Absolutely. Thank you so much for sharing.
No
I
problem.
just want to read a quick comment, Phil, when you were talking about exercise and stuff. Someone had just put that's really encouraging.
Yeah. Yeah, that's awesome. And it is open to people in Ontario. Anybody it's all virtual. So it's great, and it's through Parkwood. They could always get a hold of me, and I can send them a link to the person if they're interested. Anybody's interested. We do. I think there's 7 classes right now. There's they just switched a couple classes around. Just trying to think. There was Mondays now is boxercise, Tuesdays aerobics. I know there's a strength training class. There's a couple classes I don't attend because I don't have the time to do all 7. There's Wednesday we do a circuit. It's kind of like a CrossFit using the bands and little weights and stuff like that. Now Thursday is what we call high intensity yoga, HIIT yoga, which was today we did, and then tomorrow is the relaxed yoga. So it's like the wind down for the weekend. So, but there is.
We're going to send out, Phil, and just to everyone, which I think I forgot to mention this at the beginning, we'll be sending out a thank you email for attending, and the link to this presentation will be in there. And I can also
Great.
a link so that people can find
Fantastic.
out about the exercise
Yeah.
program as well. Okay. So we'll just let Dr. Todd continue on with the rest of the presentations. And again, please feel free to put your questions and comments in the chat box as well. And thank you for sharing, Phil.
Oh, no problem, Julie. My pleasure.
Awesome. Thank you. So now that we just spoke a little bit about exercise and we heard kind of firsthand experience from Phil about how exercise can actually supported his personal neuropathic pain experience, knowing what treatments actually help you is super important, both from an advocacy perspective, as well as from, hey, my life actually is just better because my pain is not as bad. But one key issue that emerged throughout my entire research program, and while talking with my partner and my research partners, is that many people who experience neuropathic pain and have a spinal cord injury aren't exactly sure about how to communicate their neuropathic pain. So naturally, this is very important, and I couldn't quite let this go any further without unpacking it a little bit. So we decided to do a little bit of investigation and see how do people with a spinal cord injury actually talk about what their neuropathic pain feels like. So we completed a study that aimed to evaluate neuropathic pain characteristics, again, amongst a sample of already physically active people with a spinal cord injury, and then compare whether they reported more symptoms when they were prompted with a standardized symptom-based questionnaire, so where symptoms were given to them and respondents had to just say yes or no, or when they were given the space to discuss their pain symptoms independently through a one-on-one conversation between myself and the participant. So we completed this study with physically active individuals with a spinal cord injury because research shows that active individuals often have a greater awareness of their internal body sensations, things such as fatigue, heart rate, hunger, and pain, because especially when competing at an elite level, they have to be in order to be able to perform at their best. So because of this greater awareness of bodily sensations, they often have a greater ability to accurately identify these internal sensations. So additionally, people with a spinal cord injury who are physically active, as we're talking about the benefits of exercise, may be less likely to have secondary health complications, such as cardiovascular disease or diabetes, that may also influence their pain interpretation. So therefore, in order to increase and improve the likelihood of informed pain identification and being able to really understand neuropathic pain amongst people with a spinal cord injury, we investigated neuropathic pain experiences and communication amongst people who were already physically active. So overall, what we found was that the majority of individuals in the study had paraplegia, experienced a traumatic spinal cord injury, and had incomplete spinal cord injuries. For participants' worst pain problems, what they consider to be the most intense, the majority experienced neuropathic pain below their level of injury, primarily located in their buttocks, hips region, followed by lower legs and feet. And when prompted with this kind of symptom-based questionnaire that I spoke about, most participants reported their neuropathic pain as tingling, burning, or pins and needles. So unsurprisingly, participants reported a greater number of neuropathic pain symptoms when provided with a yes or no symptom-based question compared with the number of symptoms they reported during this one-on-one conversation. So through this one-on-one interview, we were really able to identify the difficulties people with a spinal cord injury have with communicating their neuropathic pain symptoms. So I've chosen to highlight two kind of main pain categories today. So first, 55% of our participants reported that their pain was kind of ambiguous and that they barely understood what neuropathic pain was, nor if they actually experienced it. And these names that I've allocated to participants are pseudonyms. So we did not actually have a Sarah or a Joel participate in our study, just so you're aware. But one participant in our study identified that they've never really been quite sure if what they were feeling was neuropathic pain, because it wasn't really a pain that they would remember before their spinal cord injury. Like it wasn't like poking yourself in the eye or anything like that. It's just something that's really annoying. The second category that emerged through this interview was that individuals really struggle with describing their neuropathic pain symptoms. So 68% of our participants reported that it was really challenging to discuss their pain and inform others of their symptoms. For example, when we asked Joel, just saying, "Can you tell me about your neuropathic pain? What does it feel like?" His response was, "That's sort of a hard one. Maybe is discomfort super vague? It's so hard to describe." So overall, this is a really high level analysis of a really, really large problem amongst people with a spinal cord injury who experience neuropathic pain. Understanding what it is and translating that experience for individuals who hopefully are trying to help you, but don't have that lived experience. So these symptom-based questionnaires should be used in these clinical settings and advocated for by people with lived experience. And we also must continue to develop knowledge resources for people with a spinal cord injury, their loved ones, and healthcare practitioners in order to ensure that an increased number of people are aware of what neuropathic pain is and how it's being experienced. This improved knowledge and communication will help to track when treatments are effective or not, identify when to change treatments, and to support individuals with lived SCI neuropathic pain to advocate for improved management. So they're not just told to go live in an old folks home right now, and also how to advocate for modified treatment options. And knowledge is power, which we really must harness when we're talking about our pain experiences, because this can undoubtedly help make it easier to manage your overall pain. So as we're talking about neuropathic pain communication, I really wanted to highlight a resource that has been developed by our colleagues at the Miami Project to Cure Paralysis down in Florida. So they developed recently, I believe in, I guess it's 2024 now, probably 2023, this informative resource that's aimed towards improving knowledge about chronic pain among people with lived SCI experience, their significant others, family members, and caregivers. So it's really driven to the individuals who are living it, not for the researchers and not necessarily for the healthcare team. So if it's of interest, really, I can also share this link to be shared out as something that could be a valuable resource for individuals on this call. And based on the difficulties observed with communicating about neuropathic pain experiences, this is just a sample on the right-hand side here of how to start tracking and monitoring your pain in order to facilitate these improved communications with support providers and your healthcare team. So a really good tip that I was provided, and in previous research that I didn't have time, unfortunately, to discuss today, is the importance of a pain diary. So a pain diary is basically this written record that helps you track when you have pain, how bad it is, whether your treatment is helping, and sort of what your situation is around this painful time in your day. So keeping this diary gives you clues about your pain, when it happens, what causes it, and what makes it worse or better, hopefully. So these pain diaries can really help you understand your own triggers and understand how your pain impacts your life. For example, how it impacts your mood or your sleep, or how your pain interacts or interferes just with your activities of daily living, like getting in and out of bed or going to get groceries or playing with your kids. It can give you a better understanding of how your pain is a full whole body experience. So by tracking how your body feels at different times and sort of what came before the painful experience and what may have helped, it may help your healthcare team identify very tailored management options that influence different aspects of the pain experience. Because remember, pain is far more than just physiological. It can be psychological, physiological, or these sort of interacting social aspects. And I have one more slide, and I might have just seen a raised hand, but maybe I can just finish with these final messages, and then we can take kind of final questions at the end. So basically, if we were to think of some take-home messages here, I would like just really overall high level is that I hope you take home what the difference of neuropathic versus musculoskeletal or muscle-related pain is, whereby muscle-related pain has known triggers, is often the result of an acute or chronic soft tissue injury or bone break, and could be due to an overuse injury. Whereas neuropathic pain is actually due to these improper signals being communicated between the brain and the spinal cord. When we ask how much exercise is best, so the jury is still out on the optimal amount of exercise to reduce neuropathic pain, but we're definitely starting to recognize that exercise intensity and frequency matter. So really, again, tracking how moderate intensity or how high intensity exercise works for you will really help you to get this overall kind of pain reduction if exercise shows to be an effective management option for your pain experience. We also really want you to understand how your pain is impacting you, because neuropathic pain can impact an individual beyond its physical location. So again, this pain can impact your sleep, mood, family, work, and on days that you may be feeling like you're really grumpy or really frustrated and you're unable to identify why, really start thinking, am I in pain, but I'm blocking it out? Because you're so used to doing that. It really helps you take control again of how your body is feeling and how that's then interfering with your daily life. And next is how to communicate your pain with your medical team. So use resources available to you to best inform you about your pain experience, using things like I just showed you, the C-Pain resource from the Miami project, which again, I'll share a link to. And also try to discuss using standardized symptoms, things such as burning, tingling, electric shocks, squeezing, uncomfortable. These are all symptoms that have been validated amongst research so that the healthcare team should be able to be aware and diagnose that what you're communicating is truly neuropathic pain. And also be comfortable in advocating for a treatment switch. Unfortunately, the information communicated from research to the clinical world is not always communicated as quickly or as effectively as possible. So sometimes it is really harnessing that power in your pain experience, becoming your own self-advocate, as frustrating as that is, because it seems like we're always needing to advocate in the healthcare system and we just want someone to tell us what will work. But really, really understand and take control of that pain. And lastly, really monitor these pain symptoms, understand your triggers, update your medical team if your pain changes, and then really, really take control of your pain experience. And that's all I have for you today. Again, these are some of the funders that I have on the screen that funded some of my work, of which I'm very grateful for. And I'm very grateful to my lab and my partners and everyone who's helped guide all my research. And I hope that collectively we're able to identify neuropathic pain management options for all individuals living with this very debilitating chronic condition. Any last questions?
Thanks, Dr. Todd. Yeah, I think Phil, you were going to say something?
No, I just unmuted. Sorry.
Oh, that's okay.
I was just going to say thank you very much. I really appreciate this. This has been very helpful.
Now, there was a hand up by someone and then they put it down. So I'm not sure if you still wanted to ask your question or if maybe you changed your mind. But if you'd like to ask, go ahead and just unmute.
Just for information, I take CBD 31% at about 8 o'clock, and then THC 33% just before I go to bed. And for about 36 years, I was up every night, spasms, can't sleep, whatever like that. And since I've started taking that, I usually sleep from about 10:30 till 6:30 or 7 o'clock in the morning. And I didn't do that for 35
Wow.
years.
Wow, that must have had such a positive impact on
I
your life
still
at night and during the day.
I still wake up and I say, yes, I did it again.
But look at you, you took control of your own individual experience, right? And you didn't do it for some odd years. And I'm sure eventually someone told you, or you found this information that cannabis might support you. You tried it, and now looking at the benefits that you're experiencing. So again, it's this common thread of not giving up on something that might help, no matter how frustrating it is to keep having to go treatment to treatment to treatment,
Mhm.
but just knowing that you're taking control of the situation and seeing the positive impacts that it's having on you must be extremely liberating.
Yes, something else I'd like to mention. What I used to go to the gym every morning, which worked out really well. Then COVID come on when everything was closed, and then the gym was closed for
Mhm.
another year after because of staffing, whatever. And anyway, since then my pains got worse, and I've been having trouble getting back to the gym on a regular basis. So what you informed us today, that say get my rear skinny little arse out of bed and get. So anyway, thanks so much for your time. It was very informative.
No problem. Thank you so much for coming and taking your time. And as a coach and as someone who definitely enjoys physical activity themselves, in addition to knowing the benefits of exercise on chronic pain, get your arse out of bed and get to the gym.
Yep.
Okay, we've got I think it's a comment. We just put it in this chat box. It's a bit off the topic, but if there is any time left, would you impart any wisdom on what the family members of a patient with the intense, constant neuropathic pain 24/7 with a traumatic spinal cord injury can help the patient, aside from encouraging them to exercise, loving the patient the way they need to be loved while emotionally protecting oneself, if that makes sense?
Again, very full of the loaded questions. I would say, so again, I don't have, personally, I didn't tap into this from a research perspective, but using a combination of my own lived experience together with just the general research knowledge that I'm aware of. I would say step one, from what I'm often told by my partner as well, being told it's okay, it's okay to kind of be in pain, you're fine, or just trying to encourage them through it. It doesn't often work. A lot of the time, it sometimes can be viewed as not necessarily patronizing, but not necessarily listening to the full experience that an individual is having. But it does play a toll on the person, on the loved one, right? You witness your partner in pain. You don't want to see them in pain, but you know that I can't actually take that pain away from you, which is super challenging. So I think, again, what I've been told is really prioritizing your own self-care and knowing that you have this allocated time to be supporting your partner while they're in pain. So if you see your partner experiencing debilitating neuropathic pain, when they wake up out of bed, then here's your 20 minutes where you try to support your partner or your child or your parent, whichever loved one that it may be, and you try to say, okay, tell me how you're feeling right now. Again, I can help you try to take control of it. We know that this sort of treatment or this management option kind of helped a little bit. Why don't we try that right now? If it does help, awesome. If not, you kind of have set this boundary for yourself as well, where you have this sort of 30 minutes or 20 minutes where you are living that pain experience with your loved one. You really try to meet them where they're at. And if they just want to be grumpy, I know it's challenging as well, and I can definitely vouch for that. But sometimes individuals need that space to just be able to live their pain experience the way that it's impacting them that day. And then that here's your 30 minutes. And then eventually you're able to try to move through it and try to say, okay, now I'm focused again on myself, and we're going to try to carry through our day. So a lot of it is still trying to support your loved one, meet them where they're at, try to suggest additional distraction techniques, which again, I can share in this C-Pain resource, which is extremely valuable for support providers as well. But keep your own boundaries so that you're able to still be emotionally sane, because it can be extremely draining, and in neuropathic pain and chronic pain does impact sort of the overall family dynamic and friend dynamic as well.
There was a comment. Thanks, Dr. Todd. There's one said super helpful, thank you. Another one said mindfulness helps as well. There's another question, and I'm not sure. So it's what were the two first things you were comparing?
So was that in terms of muscle-related pain and neuropathic pain? That was kind of where we started the presentation at. we kind of compared those two things. And then we also compared a couple of different treatment options. But if there's any, if you want to pop on and say sort of if there's any target as to what those two first things we're comparing, in case I didn't touch on it, or else my email address as well can be shared, and feel free to reach out to me directly if you prefer not to pop on.
Sorry, it was the very first thing you were talking about. You were comparing, and I couldn't grab a pen fast enough. It was too fast for me. I'm sorry.
No, I apologize. So yeah, the very first few things that we were sharing was about comparing neuropathic pain and musculoskeletal pain, just to really share what those two differences were. Yeah. So basically knowing that musculoskeletal pain is usually because you have damage to soft tissues or to your bones, tendons, ligaments, etc. Whereas neuropathic pain is something that is a disconnect between the signals that are shared between your brain and your spinal cord. That is, in this case, a result of your spinal cord injury.
Thank you.
No problem. Thank you for the question.
And just to remind everyone again, the link will be shared with you to this presentation. So if you did miss anything, we will send you the link so you can rewatch the session. Is there any other kind of last minute questions or comments for Dr. Todd?
Thanks very much for the presentation. That was amazing. Lots of info in a short period of time.
Hopefully not too much. I tried to make sure that I was concise, but when you're passionate about something, unfortunately, it tends to keep growing and growing. So I tried to really condense it because my slides were way too long before.
Well, it's such a huge issue. And oh, sorry, go ahead, Jackie.
No.
I was just going to say, and I don't know, Jaspreet, if you want to, if you have a comment to this as well. So speaking with a lot of my peers daily, I find that bowel and bladder and neuropathic pain are probably the three biggest subjects or questions or concerns that individuals with spinal cord injuries have. And like you said, it's hard, right? Everyone can share what they do, but it's so individualized, maybe what's going to work for you and what's not. So it's nice that we have peers that can share, and thank you to you for coming on and kind of giving us information from the research side, as well as your personal knowledge that you have as well. It's been awesome. Thank you.
So reaffirmed.
Thank you guys for your time. It was very informative. Thank you so much.
Thank you, Ron. And thank you all for joining us. As always, every month we do the virtual peer connection. So just go onto our website at sciontario.org and look up events, and you can see what we have in the upcoming months. So we hope to see you all there. Thank you so much for joining. Thank you, Jaspreet, and thank you so much, Dr. Todd. Really appreciate the time.
Perfect. Thank you.
Thank you so much. Appreciate it.
Thank you. Thank you.